So great. So the next talk is by Professor Anant Madabhushi, who is a Donnell Institute Professor of Biomedical Engineering at Case Western Reserve University, Cleveland, and Director of University's Center for Computational Imaging and Personalized Diagnostics. He's also a research scientist at the Louis Stokes Cleveland Veterans Administration Medical Center and has affiliate appointments both at university hospitals and Cleveland Clinic. He holds secondary appointments in the Department of Biomedical Engineering, Urology, Radiology, Pathology, Radiation Oncology, Electrical Engineering, and Computer Science and General Medicine. Today, he'll be talking about artificial intelligence, radiomics, and pathomics implication for precision medicine. Over to you, Anant.
Great. Thank you very much for that introduction, Arun. So real pleasure to be here this morning and present some of the work that's happening in our group at the Center for Computational Imaging and Personalized Diagnostics. Just want to get my conflict of interest disclosure out of the way. So just as a disclaimer, I do work with a number of companies to help translate some of the technologies that we're developing in the lab out into clinical deployment. But perhaps my main disclosure, if I may, is the fact that I do have a social media presence. I have a social media account, a Twitter handle right there. If there's any of what you see today that you find remotely interesting and you are on Twitter or social media, please feel free to give me a handle. All right. So I want to set the stage a little bit for what I want to talk about today by talking about cancer and talking about cancer statistics. So one of the most staggering statistics that I became aware of a few years ago was the fact that in the United States, 40% of the adult population will be diagnosed with some form of cancer in their lifetime, right? So we hear about cancer and we think that it's something that happens to other people. But when you look at the fact that 1 in 2 men and 1 in 3 women in the United States will be diagnosed with some form of cancer in their lifetime, that's a very sobering statistic, right? That means this is not happening to just other people, right? You are likely going to be affected in some way, shape, or form with cancer over the course of your lifetime. Now, when you look at the actual mortality on account of cancer, there's a little bit of a discrepancy between the diagnostic incidence and the actual mortality on account of the disease. So what we actually see is that even though the number of people dying because of cancer is still a pretty large number in the US, it's about 600,000 people, men and women, who are dying because of cancer every year. There's clearly a discrepancy between that statistic and a 40% diagnostic incidence rate. So what explains this? Why is there so many more people who are going to be diagnosed with cancer as opposed to people dying because of cancer? Now, there are a few different reasons for this. One is we know that we are using imaging in a more aggressive way for screening and identifying and diagnosing cancer at an earlier stage. We have a number of biomarkers that allows us to identify cancer at a much earlier stage. And we know that the earlier that you find the cancer, the better the prognosis, the better the outcome, the better the survival. But if we're completely honest, we have to recognize also that part of the reason for the discrepancy between the diagnostic incidence rate and the actual number of men and women who are dying because of the disease, a large part of that is driven by overdiagnosis and overtreatment of cancer. Okay, so what does that mean? Let's take the example of prostate cancer. Prostate cancer is a disease that affects men. Specifically, 1 in 7 men in the United States will be diagnosed with prostate cancer in his lifetime, but only 1 in about 40 men will actually die on account of the disease. And the reason why we talk about overtreatment, overdiagnosis of prostate cancer is that because the vast majority of prostate cancer that is diagnosed tends to be fairly indolent. In other words, it is not aggressive. It tends to be a slow moving disease. And chances are that if you're a male and you have prostate cancer, chances are that you're probably going to die with prostate cancer rather than on account of prostate cancer. And yet today, we end up treating a lot of prostate cancers very aggressively. We end up treating them with surgery. We end up treating them with radiation therapy. Treatments that could possibly be avoided because the vast majority of these men will likely benefit from no intervention. They will likely benefit from what is called active surveillance, where you just try to monitor the disease without actually trying to interfere with the disease. And yet, because we end up being conservative and end up trying to treat a lot of these prostate cancers very aggressively through surgery, through radiation, that apart from causing toxicity to the patient, causing real harm to the patient, there's also the very real issue of financial toxicity. So what is financial toxicity? Look at the statistic here. About 42% of new cancer patients will lose their life savings because of a cancer diagnosis. And you can read the other statistics at the bottom of the slide. I mean, this is staggering, right? We're seeing that there is such a huge cost associated with cancer. And in many cases, this cost is really avoidable, because what we have here is a situation where a lot of indolent cancers are being treated aggressively, and the cost of these treatments is humongous. I mean, a radical prostatectomy is tens of thousands of dollars. Immunotherapy drugs, which I'll talk about subsequently, a new class of drugs that have changed the landscape in how we treat cancer today. These drugs cost something in the order of $250,000 per patient per year, and yet only about 20% of cancer patients treated with immunotherapy are going to respond to immunotherapy. And so there's a real issue here in how can we help address this issue of overdiagnosis and overtreatment, and thereby help reduce the number of patients who are getting overtreated, who are suffering from financial toxicity, and of course, suffering from a real issue of toxicity because of these treatments. One of the collaborations that we have ongoing is with the Tata Cancer Center in Mumbai. And with the collaborators I have at the Tata Cancer Center in Mumbai, one of the issues that comes up constantly is that even though the Tata Cancer Center is the largest cancer center in Asia, there is still a paucity of resources and treatment options for patients. In other words, there has to be a more careful and judicious way in which we select treatments for the right patient. Because in India in particular, not only are these treatments expensive, there's also a lack of sufficient arsenal of treatments to be able to treat everyone. In other words, we have to be very careful and judicious in who we treat and how we treat. And so that leads me to the point of the work that we're doing in our lab, which is really focused on AI, computational imaging, radiomics, pathomics from routinely acquired data. We're talking about MRI scans, CAT scans, pathology images. And what we're trying to do is really address some fundamental problems in the context of precision medicine. One is diagnosis. And right now, when you hear about AI in medicine, a lot of it is focused on diagnosis. And diagnosis is fundamentally trying to figure out whether you have a disease or is there no disease present. But I mentioned a statistic to you. 40% of the adult population in the US will be diagnosed with some form of cancer. So the fact is that a vast majority of men and women are going to have cancer. And the question now is, what do you do about it? And like I said, the big issue in cancer patients, in fact, for a lot of diseases, once the diagnosis has happened, you still have a very big issue of how to manage the patient. Do you give them aggressive therapy? Do you maybe reduce the aggressive therapies in these patients? We know that a lot of breast cancer patients can successfully avoid chemotherapy. They don't need chemotherapy because they have less aggressive breast cancer. So how can we use AI? How can we use radiomics and pathomic tools to be able to better risk stratify patients and help avoid unnecessary and aggressive therapies in a vast majority of patients? So that's really fundamentally the goal of a lot of the work that we're doing at our center. Now, I want to quickly also qualify here that what is really driving these predictions is ultimately patterns and features that we're getting from the images, right? So as we think about deep learning, as we think about AI today, we usually think of this black box approach where we send in images, we generate some representations, some predictions, and use that to predict the absence or presence of disease. What I'm suggesting here is that there are alternative ways in which one can go about designing these machine classifiers. And a big part of the alternative strategy is really around finding predefined representation, or what we call in our group interpretable imaging biomarkers. In other words, what are the kinds of features, what are the kinds of patterns that we can derive from routinely acquired data, MRI scans, CT scans, pathology images, that provide more information than can be visually discerned by a pathologist or radiologist who's looking at these scans. Now, a big part of this are called, is radiomics, where you can go in and find texture patterns relating to the heterogeneity of the disease from a CT scan or an MRI scan. One is able to capture more quantitative measurements that reflect the shape and the patterns of the tumor or the nodule on a CT scan. And all of this gives us quantitative descriptions of the appearance of the disease that can then be linked not just to disease diagnosis, but also prognosis and treatment response. I mentioned deep learning, and deep learning, a large part of what deep learning fundamentally is a set of neural networks that can be arranged in various different architectures. And fundamentally, the idea is that you can do what is called unsupervised feature generation. And the big flexibility and the opportunity with deep learning based approaches, of course, is the fact that you can provide images directly that are labeled to these neural networks. Given a particular object of interest, the network is able to learn patterns connected to that object of interest, and then is able to go in on new images and identify those precise objects of interest. As an example here, this is work that we published a few years ago where we were trying to use deep learning to go in and segment out nuclei or cancer cells from pathology images. So all we had to do was have a pathologist identify the individual cells, create annotated examples or a training set with these annotated examples that then went to the neural network. The neural network learned the appropriate representations from those cells and was then able to spit out the segmentations of those individual cells. Now, the big challenge with deep learning, as I'm sure a lot of you are aware, because the theme of this workshop is really around explainable AI or interpretable AI, is that a lot of these AI approaches tend to have very abstract representations. And yes, there are ways in which you can use visual attention maps to try to figure out what the network was looking at. But fundamentally, the network is learning largely in an unsupervised way. I mean, even though you've got the training examples that are provided to the network, the process of feature generation is largely unsupervised. In other words, the network learns abstract representations that best distinguish the features of interest, and therefore there's really no way in which we can provide that explainability inherently to these neural networks. Now, why is all of this relevant? Like I said, the big question today in the context of a number of different cancers is being able to identify which cancers are going to need more aggressive treatments and which patients are going to avoid or can avoid aggressive treatments. And one classic example is in the context of early stage breast cancer. In early stage breast cancer, most patients will get surgery and chemotherapy. Now, the vast majority of women with early stage breast cancer don't need chemotherapy. About 70% of them don't need chemotherapy. And because 70% of them don't need chemotherapy, what we really need are ways in which we can really distinguish the patients who can avoid this aggressive treatment from the patients who actually will need it because they're more aggressive disease. But one of the breakthroughs that happened about 2 decades ago was this test called Oncotype Dx, which is a molecular assay, which looks at the gene expression of the cancer, was developed, and it was able to produce a risk score. In other words, it was able to provide an assessment of the cancer, and essentially, if you had a high risk score, it was a reflection of the fact that you had more aggressive disease. If you had a low risk score, it was a reflection that you had less aggressive disease. And so if you had a more aggressive disease, you needed the chemotherapy. If you had less aggressive disease or a low risk score, you could avoid the chemotherapy. But the problem is this particular test is very expensive. It has it's at a cost of something like $4,000 per patient. It also destroys the tissue. And one of the problems with these tests is that they are focused really on sampling a small part of the tissue. And one of the things that we know about cancer is it's very heterogeneous. And because the cancer is very heterogeneous, when these tests are conducted, they involve a small part of the tumor, and therefore the risk assessment one gets may not be a true reflection of the true aggressive potential of the tumor. On the other hand, what we've seen over the last decade and a half is a true revolution in digital pathology. In other words, pathology images, which is what pathologists look at to render a disease diagnosis, now are becoming commonly available in a digital form. That is, you can have whole slide scanners that essentially you can put these slides in, you can digitize the slides, and you can generate high resolution images of pathology tissue like the one that you see here. And once you have that, now we can start to extract more interpretable imaging biomarkers that can tell us not just about the presence or absence of disease, but can actually start to tell us about which of these cancers are more aggressive, which ones are less aggressive, which ones might need chemotherapy, which ones could avoid chemotherapy. And just some examples of these patterns here. For instance, you can use network theory or graph theory to start to look at the spatial arrangement of individual cancer cells. One can start to look at the heterogeneity and the texture of different tissue compartments and stroma in the epithelium, with the result that one can now convert these digital pathology images into quantitative imaging features that provide a more reproducible way and a more explainable way of coming up with an interpretation, coming up with a prediction of what the aggressiveness potential of the disease is. And so I was focused on this concept of using these more explainable, interpretable imaging biomarkers for about a decade and a half. And one of the ideas that we came up with about 12 years ago was, could we use these patterns, these explainable biomarkers that we were mining from these images, to create what we call the image-based risk score. I talked about the genomic test, the Oncotype Dx test, to be able to predict which cancers needed chemotherapy and which cancers could avoid chemotherapy. But like I said, that's an expensive test. And so what I started to think about was, how could we use routinely acquired images from tissue samples, digitize them, go and find explainable biomarkers from these images, and then use that as a way of being able to predict outcome and predict therapeutic response and which patients needed chemotherapy. So we came up with this concept of the image-based risk score, or IBRIS. And IBRIS did actually use some of the deep learning algorithms, but fundamentally we use deep learning only as a way of trying to identify the presence or absence of individual cells and find the primitive structures from which we could then go in and extract the features of interest. Now, one of the things that we also learned about deep learning is that the abstract representations can really be an issue if you're trying to predict higher level diagnosis. If you're trying to make a direct higher level diagnosis directly from the slides without this interpretable imaging biomarker approach, which is you're just sending images to the classifier and trying to make interpretations, there is a real challenge with that. So this is a paper that we published a couple of years ago where we were trying to use images from endomyocardial biopsies to be able to predict which patients were going to have heart failure from patients who were not. And essentially what happened was we were able to get a classifier that seemed to work very well. We were able to generate a classifier that had, you can see here, a very, very high accuracy, something like 99% sensitivity and an area under the curve of 97%. And so when we compare that to human pathologists doing the diagnosis of heart failure or not on these endomyocardial biopsies, we found their performance was only about 74%. So there was a 25% improvement with the deep learning classifier. But subsequently, when we got a second batch of images from the same lab, we found the performance of the deep learning classifier went down significantly. It went down to about 75%, a significant decrease in the overall performance. And so that got us thinking, like, what happened? Why did the classifier suddenly go from 97% down to 75%? And what we realized was that the scanner that was being used to scan the images had a remote software upgrade applied to the machine. And because of that remote software upgrade, the classifier that we had previously found at a 97% area under the curve now was not as robust, because subtly the software upgrade to the scanner had changed the images in a very, very mild, imperceptible way, but enough to perturb the network. And so this again reiterates the point that when you have a lack of interpretability with your classifiers, like with deep learning, the challenge is if something changes in the system, then it might have adverse consequences for your deep learning classifier. And the lack of explainability causes problems because then you don't know how to fix the issue, right? And this is an issue, obviously, that is the theme of the workshop and theme of the network today, theme of the conference today. But this is an issue that is echoed by many, many experts. For instance, Professor Jordan at UC Berkeley has talked about this. Cynthia Rudin at Duke University has talked about how we need to stop trusting the black box, especially for high stakes decisions, like in the area of precision medicine, like in the area of healthcare, where the decisions are really high stakes because you're talking about life and death situations. And if you're talking about predictions about whether somebody should get chemotherapy or not, these are really high stakes decisions. And so if you don't understand your classifier, then you've got a real issue with getting your clinician, getting the doctor, getting the physician to recommend a treatment based off a box or based off a classifier that you don't understand how it arrived at its particular decision. And this is a classic example I like to tout, from Sameer Singh at UC Irvine, where he and a student worked on a problem to try to distinguish between huskies from wolves. Huskies and wolves are animals that look very, very similar. Human beings can't really tell them apart looking at the animals. And they trained a classifier to try to distinguish these huskies and wolves and found that the network, the deep learning network, the neural network they trained had an almost 100% accuracy. Now, Sameer Singh, who is clearly extremely smart, realized immediately that there was a problem there, that these classifiers could not be performing this well because humans themselves struggled to distinguish huskies from wolves. And so what they were then able to find was that the reason the network was doing so well was that it had recognized that huskies, which tend to live in cold climates, in cold areas, the images of huskies invariably were on a white background because there was some snow in the background. And because there was snow in the background, the network was picking up attributes of the snow. It had nothing to do with the face of the animal. And so that's really what the network was learning, and that's what the network was using to really distinguish huskies from wolves. It had nothing to do with the features of the face of the animal. And so that's why we have avoided using deep learning to make direct predictions about outcome, to be able to make predictions about therapeutic response from pathology images or radiology images, rather using deep learning as a way of deriving features or deriving specific primitives, specific structures in the images from which we can then derive interpretable imaging biomarkers. So you can see here an example of work that we published where we showed that you could use these machine learning classifiers or deep learning classifiers to identify cells in the image, to distinguish tissue partitions, to distinguish stroma from epithelium, distinguish different glands, different tubules, different types of structures. And you can see here in this video that these networks can be very powerful for segmentation detection. I mean, this is a 40,000 pixel by 40,000 pixel image of a cancer where the network is able to very quickly go in and identify the cells of interest, hundreds of thousands of cells, very, very quickly using a neural network. But the thing is that this segmentation of the deep learning is really only powerful because it lays the basis of allowing for the process of extraction of interpretable imaging biomarkers. So in other words, we can now use this to separate out the different tissue compartments, identify different cell types. But now using things like graph theory, network theory, we can start to prize out more interpretable statistics relating to the spatial architecture and the spatial arrangement of different types of cells, and now use these spatial statistics of the different cell types to now start to make predictions of outcome, to start to make predictions of treatment response. So what I'd like to do over the next few slides is to give you examples of some of these interpretable imaging biomarkers that can be used to make predictions of outcome, to make predictions of therapeutic response. Now, one paper that we currently have in press in Nature Breast Cancer is work we've been doing with breast cancer images to be able to predict outcome. And one of the things that we focused on is looking at collagen fibers. The collagen fibers, are long recognized in pathology images as being the basis of, outcome and aggressiveness of a number of cancers. We know that the arrangement and the architecture of collagen fibers can actually tell us about which patients are going to do worse and which patients are going to do better. In this study, what we were able to do is to use deep learning to identify the tumor areas. You can see that in green. We were able to use the the deep learning also to identify the collagen fibers, which are these sort of strands of fibers that crisscross the tissue. But what we were able to do then was to assign vectors to the collagen fibers. So you can actually see here there are arrows that represent the direction of the collagen fibers. And what we were able to do was to essentially use the concept of entropy to look and to characterize the orientation of the collagen fibers. So essentially, what we found was that in patients who tended to have short-term survival, that is, they did poorly, they tended to have poor outcome, versus the patients who had long-term survival and therefore had better outcome. What we found was that in patients who did poorly, the collagen fibers were all pointing in the same direction. Patients who did well, the collagen fibers were all over the place. They were very haphazardly arranged. And that actually makes sense when you think about it, because why do people die because of cancer? People don't die because of a primary cancer. They die because the cancer spreads. The cancer goes to different parts of the body. And so if you think about it, the fact that you've got collagen fibers that are arranged very nicely in a very ordered manner means that the cancer cells can hitch a ride on those collagen fibers and migrate from the primary site to other regions in the image and cause metastasis, which can then cause cancer-specific death. On the other hand, if you find that patients who tend to have longer-term survival, patients who tend to have better outcome, those patients, the collagen fibers, the fact that it is more disordered, it is more chaotic, means that it is more difficult for these cancer cells to hitch a ride and really migrate from their primary site elsewhere. And so what we were able to do was to essentially look at the order or the disorder using entropy of the collagen fiber orientation to really distinguish between patients who had poor survival versus patients who had much better survival. And what we found was that this feature, this quantitative imaging biomarker, was strongly associated with survival. And this paper, like I said, should be out in the next week or so in Nature Breast Cancer. So that's just one example of an interpretable imaging biomarker where deep learning is used for segmentation, but beyond that, the features are really capture the biology, capture the domain specificity of the particular disease, and allow us to make predictions about outcome. Here's another example of work that we recently presented at the San Antonio breast cancer meeting, where we found that if you look at other features in the images, for instance, just capturing the features relating to the disorder in the appearance of nuclei, looking at features that reflect the density of tubules or mitotic counts in breast cancer images, that if you could take these features, again, reflecting the biology of the disease of the breast cancer, you combine them into a machine classifier, and we were able to demonstrate across multiple different sites, across multiple different labs, different countries. In fact, this is a collaboration with the Tata Cancer Center in Mumbai, that this particular set of features, all of which are very interpretable, very intuitive, was able to prognosticate outcome, was able to predict survival in breast cancer patients across multiple different labs, multiple different countries. And again, the nice thing is, one of the things I want to stress here is the fact that when you see that these features, not just the fact that they're accurate, but the fact that they're able to work across different labs, different countries, that means a lot, right? Because that means that your features are reproducible, your features are stable. So one of the things I want to mention here with interpretable imaging biomarkers is not just the fact that you get interpretability, but you also get stability, you get reproducibility. And that's a really critical aspect as you think about explainable AI. It's also the need to have stability and reproducibility across sites that's really important. Now, why is IBRIS important, right? So we talked about fundamentally an image-based test that uses digital pathology images to be able to make a prediction of whether you need chemotherapy or not. And so this is a little bit of my tongue-in-cheek comparison between Oncotype Dx and IBRIS, the image-based risk score. One is the cost, right? This Oncotype, these molecular-based tests are extremely expensive, but the beauty with IBRIS is you're talking about interpretable imaging biomarkers that are coming from tissue images. And essentially, you're talking about a cost that's pennies on the dollar compared to these very expensive molecular-based tests. You're talking about a test that takes literally 20 minutes to do compared to tests that take 2 weeks. You have, you're not destroying any tissue. You're talking about digital images to build the assay. And therefore, because you're talking about digital images, you've got a global impact. You've got a worldwide impact. You're not limited to the US alone. In other words, you have an inexpensive, fast, reliable, accessible prognostic breast cancer test that's priceless for everything else that's MasterCard. So for those of you who recall the MasterCard ads, hopefully you'll find a little bit of humor in there. But my point is that these tests that are, non-destructive, that essentially just use, routinely acquired data such as pathology images can really have a massive impact in precision medicine, precision oncology, particularly in low middle income countries like India. And there's a big opportunity to combine these interpretable imaging biomarkers with more advanced, sophisticated tests like Oncotype Dx and show that the interpretable imaging biomarkers can actually significantly improve the performance of these very expensive molecular-based tests as well. And just many, many different examples of where these interpretable imaging biomarkers can play a role. This is another type of breast cancer, what's called stage 0 breast cancer or ductal carcinoma in situ, where the big challenge is trying to figure out whether this stage 0 breast cancer will progress to invasive breast cancer, or invasive ductal carcinoma in situ. And even here, our group has demonstrated that looking at interpretable imaging biomarkers, looking at the shape of individual cells, looking at the orientations of individual cells, can allow us to figure out which of these DCIS will progress on to invasive ductal carcinoma versus those which will not. In a recent paper we just put out in Nature Precision Oncology, we showed that looking at the appearance of glands in pathology images similarly was highly associated with risk of recurrence in prostate cancer. Essentially, we found that if you look at patients with prostate cancer, the big question is trying to figure out after surgery whether they will have a recurrence of the disease or not. And what we were able to demonstrate in the study is that if you looked at features relating to the arrangement of glands on pathology images, that we could actually predict which patients were going to have recurrence versus patients who were not going to have recurrence. And this was a large study that we did across multiple different sites. And again, demonstrating in data from multiple different sites that having these interpretable, explainable imaging biomarkers not only allowed us to figure out which patients would have recurrence versus not, but it also allowed us to create tests that were stable and reproducible across different labs, across different sites. Just like I showed you with the Oncotype Dx test, there is a very expensive molecular test for prostate cancer called Decipher. It's a $3,000 test. And what we did in this paper was go head-to-head with the Decipher test, so essentially showing that using imaging biomarkers from pathology images, we could compete with the Decipher test very compellingly. And actually, we showed that, in fact, combining the image features, the image biomarkers, with two clinical variables, we could significantly outperform the $3,000 Decipher test. In fact, we could do twice as well as this $3,000 molecular-based test. I will skip over this in the interest of time. Now, one of the other things that's really important, and I come back to this concept of imaging biomarkers, one of the things that we also started to recognize is that we have different populations, right? In the United States, we've got African Americans, we've got Caucasian Americans, you've got South Asians, you've got Asians, you've got multiple different populations. One of the things that our group has been doing has been, can we find with imaging biomarkers whether there are differences in the appearance of cancer across different populations? And one of the things that our group has found is that not all cancers in all populations are the same. So it turns out that the cancer, prostate cancer identified in Black men in the United States with prostate cancer tends to look different, subtly, but tends to look different from what tends to occur in Caucasian American men or white men. And so in this study, we were able to demonstrate that by using a series of interpretable imaging biomarkers from within the stroma of the tumor, we were able to identify which prostate cancer patients, which Black men with prostate cancer were going to have recurrence versus not, and realize that when you think about these AI models, you have to account for population as well. That is, a standard model is not going to work across different populations. And if there are differences, specific differences across populations, you have to account for those differences and stand up population-specific prognostic and predictive models. I want to sort of just give you a few more examples here with interpretable imaging biomarkers. This is another example where we were able to find a particular cell type called multinucleation in P16 positive oropharyngeal squamous cell cancers. These are head and neck cancers, where we were able to demonstrate that the aggregates of multiple different cells or nuclei tend to be strongly associated with outcome, with poor outcome. We were able to demonstrate here, again, using deep learning to identify the multinucleation, but then creating a classifier based off the density of these multinucleations. We were able to demonstrate that we could actually predict the outcome for these cancers. Sorry, is there a question? Okay.
No.
Okay. So we were able to demonstrate that in a number of patients across multiple different sites, that this multinucleation feature alone identified by the deep learning was prognostic of survival in these head and neck cancer patients. This was a large study we just published. Again, in the interest of time, I'll skip over some of this data. One of the other things that we've also demonstrated in lung cancer, just like we did in breast cancer, is that these features that we're extracting from pathology images not only tells us about survival, but can also tell us specifically who will need chemotherapy versus patients who can avoid chemotherapy. So again, using features relating to the cells, the appearance of the cells, the arrangement of the cells on these images, we were able to really distinguish between patients who not just had different survival characteristics, but specifically were able to identify which patients would truly benefit from additional chemotherapy versus patients who could successfully avoid additional chemotherapy. One of the other areas I mentioned was immunotherapy. Immunotherapy, like I said, is a new treatment modality that has had a major impact on the treatment of cancers. We know that these immunotherapy drugs are extremely expensive, costing over $250,000 per patient per year, but it only works about 20% of the time. And so one of the things that we've demonstrated very recently is that by looking at the arrangement of cells, specifically tumor-infiltrating lymphocytes on these pathology images, we can actually predict which patients are going to respond to immunotherapy versus patients who are not going to respond to immunotherapy for lung cancer. And that's a big deal because only 1 in 5 patients is going to respond to immunotherapy. The vast majority of patients are not going to respond to immunotherapy, and yet you've got a treatment that costs $250,000 per patient per year. And so the ability to identify these biomarkers and predict response, it could have significant implications, not just for the patient, but also to the cost of healthcare. And so we've shown this not just for lung cancer, we've shown this in the context of gynecologic cancers, ovarian cancers as well. Again, really the key message I want to drive home here is that it's really about these biomarkers. It's about the spatial arrangement of these cells. It's not a black box. We're not simply sending in a bunch of images and allowing the classifier to make predictions. It's about what kind of patterns exist in these images that we can prize out, that can really tell us about the aggressiveness potential, about the treatment benefit, treatment response of these various different cancers. Now, everything I've been talking about so far has been of pathology images, but what we're also doing is looking at radiology images. And one of the problems we're looking at in our group is trying to distinguish in the context of brain tumors from MRI scans as to which patients, after they get treated for brain tumors, which of those patients will respond completely versus patients who will not respond. One of the problems with brain tumors after they get treated with chemotherapy and radiation therapy is when they come back and get a subsequent MRI scan, something shows up on the MRI scan. And the big question is, what is it that has shown up? Is it the recurrence of the cancer? Has the cancer come back? Or is it just an effect of the chemotherapy and radiation? And if it's just an effect of the chemotherapy and radiation, then that's okay. It's just a benign condition. It's not going to kill you. That's okay. The problem is, when you look at the MRI scan, or a radiologist is looking at the MRI scan, they have no way of telling, is that a recurrence of the cancer, or is this an effect of the treatment that's been applied to these patients. And because they can't tell, the surgeon has to go in, do a biopsy. That's a $50,000 procedure, and you're causing significant trauma to the patient. And so one of the things that we've been looking at in our group is how can we use features relating to the arrangement of edges, so specifically using image processing to identify the dominant edge at every pixel, and using features of entropy, that is looking at the disorder or arrangement of the arrows, these edge directions on a pixel by pixel basis, and converting these images into entropy maps like the one that you see here. So essentially, high entropy reflects more disorder, more chaos in the system. And so if you look at this particular image, the one to the left, there's a lot more chaos, there's a lot more entropy. On the other hand, when you look at the right panel, there's a lot less chaos. The entropy is much lower. And so it turns out that the high entropy is a reflection of recurrent cancers. Low entropy is associated with radiation necrosis or a treatment effect, which is benign. And so the beauty is that we were able to take images where visually you couldn't really tell them apart, but with the use of this more interpretable imaging biomarker, we are now able to figure out whether one is cancer or one is just a benign treatment effect. We've shown that this more interpretable imaging biomarker, this entropy feature of the edge orientations, has implications in other cancers as well beyond brain tumors. So for instance, we've shown that if you look at breast cancers, we're able to predict a response to chemotherapy in these breast cancer patients. So looking at an MRI scan for these patients, even before chemotherapy is begun, we're able to predict which of these patients will respond to chemotherapy versus patients who will not. And one of the really interesting things here is we're finding that it's the entropy features outside the tumor, not inside, but outside the tumor, that seem to be most associated with response to chemotherapy. And one of the things that we've done here is demonstrated, again, going back to explainable AI, right? So we've got to demonstrate why are these features working. So the study we did was to actually get biopsies from outside the tumor in these patients and looked at the tissue images, right? To understand at a cellular level what was going on. And what we found was that essentially the entropy features were the way they were because of the arrangement of the immune cells on the biopsies that we were getting from outside the tumor. And so, now you have a basis. You have a basis for explaining why your AI is the way it is, right? And so really demonstrating that this particular entropy feature is the way it is because of the particular arrangement of the immune cells on these biopsies that we were getting from outside the tumor. Another example of an interpretable imaging biomarker is the work we're doing in prostate cancer. We're looking at prostate cancer patients who will have recurrence versus patients who will not have recurrence. And we looked at the shape of the prostate on MRI scans. And we said, okay, let's look at a series of MRI scans in patients who did have recurrence of prostate cancer. Let's look at those men who did not have prostate cancer recurrence. Let's look at their MRIs. And we created atlases. We created one atlas for men who had recurrence, one for those who did not. We did a difference. We did a subtraction between the two models and found that there were clearly significant differences in the appearance of prostate cancer in different parts of the prostate. And there were clear differences in the shape of the prostate in specific regions, clearly indicating, clearly reflecting that there are significant differences here between patients who did and did not have recurrence. And it was reflected in the differential shape of the prostate on an MRI scan. One of the other things that we've also looked at is the shape of the vessels, right? So we look at the tumor, but we forget the fact that tumors are ultimately fed and nourished by vessels. There are blood vessels that are associated with the tumor. And one of the things that we've done is really trying to understand, is there something about the shape of the vessels that can tell us about whether these tumors are going to respond to chemotherapy or are they not going to respond to chemotherapy? And essentially using mathematical approaches to capture the fractal dimension of the twistedness of the vessels, we were able to demonstrate that that twistedness was directly implicated in the likelihood of response. Essentially, we found that the more twisted the vessels, the more likely these patients were to not respond to chemotherapy. The less twisted the vessels were, the more likely they were to respond to chemotherapy. And what we've also been able to demonstrate that this concept of entropy of interpretable imaging biomarkers is very, very critical in predicting response to immunotherapy. So looking at CT scans alone, we're able to identify which patients are likely to respond to chemotherapy, which patients are, immunotherapy versus patients who are not. And again, a lot of it has to do with the twistedness of the vessels. Again, an interpretable imaging biomarker where you see that patients who respond tend to be the ones with much smoother vessels, less twisted vessels. Patients who tend to not respond tend to have much more twisted, convoluted vessels associated with the tumor. Okay? And what we've also found is that when you look at the progression of the disease, when you look at these patients after treatment, the patients who tend to respond, the vessels become less twisted. In patients who don't respond, the vessels tend to either stay the same in terms of twistedness, or they become even more twisted. So again, you've got something that is more interpretable, something that you can relate to, something that is more physically meaningful compared to more abstract black box representation. So let me conclude with that. So hopefully what I've conveyed today is that computational analytics with routine imaging can help address questions in precision medicine, specifically around prognosis and prediction of response to therapy. Regardless of the choice of our artificial intelligence approach, whether you use radiomics or deep learning, what I've tried to convey, hopefully, is that there is a need to establish multi-scale disease associations. So in other words, you need to try to figure out why are the features, why are the predictions you're getting from one modality the way they are, and can we look at other modalities, other scales of data to try to fundamentally understand why those representations are the way they are. I gave the example with breast cancer where we had a pattern on the MRI scans that predicted response. We were then able to look at the biopsies from those patients and figure out that the reason why those patterns were the way they were was because of the particular arrangement of cells on the biopsy images. One of the critical things I also want to convey is the fact that we have to pay particular attention to rigorous validation. Okay, so there's a lot of buzz around AI, but we have to make sure that these approaches are stable across multiple labs, multiple sites. We talk about external test sets, right? We talk about training and validation and test sets. It's really critical that you have multiple different test sets from multiple different sites. And what is also critical, as I mentioned before, is evaluating the reproducibility of these approaches. How stable are these approaches across different labs and across different sites? And so with that, I just want to do a quick shout out to the amazing team that I have the pleasure of working with, a number of students, postdocs that we have here in Cleveland, and for students in the group, students who are participating today, who are watching this, we're always looking for bright, motivated students to work with us. So if you're interested in learning more about what we do, if you are interested in maybe doing a PhD and doing a postdoc, please feel free to reach out. We're always looking for motivated people to work with us. So I just want to put that out there, and of course, just want to thank the various funding agencies that have made this work possible. And so that's allowed our team to grow in size. But we're always recruiting. The good news is that we've been privileged to have a lot of funding. So we're always recruiting, always looking for motivated, talented people to come and join our team. So with that, I'll end. And like I said, if you're on social media, if you're on Twitter, if you liked any of what I presented today, that's my Twitter handle. So please feel free to give me a follow if you'd like to learn more about what we do. Thank you.
Thanks, Professor Anant. So I'll maybe are there any questions from the panelists? I think I see Professor Kriti's hand raised. Professor Kriti.
Is there also a need to understand? Can you hear me? Can you hear me?
Yeah, I can hear you. Yes.
Okay. Is there also a need to understand how often to do some tests? These tests are very expensive, and some, for example, leukemia, you have to test every 6 months or 1 year to make sure that the disease hasn't spread or it has some property. So do you have any way by which to decrease the frequency of tests and so on?
Yeah, that's a great question. And so this is, again, I mean, one of the things that I didn't talk about is with some of the work we're doing in lung cancer screening, where with lung cancer screening, one of the big problems is that, the goal is to try to find if you've got lung cancer, you do a CT scan. The problem is very often when you do the CT scan, you find a nodule, right? You find something on the CT scan. And then the question is, is this cancer? Is it benign? And most times radiologists will say, okay, well, we don't know what it is, so come back and get another CT scan in 3 months. But if we could, with these interpretable imaging biomarkers, more definitively say, look, this is absolutely benign. Okay, you don't need to come back. Forget about coming back for a scan in 3 months. Now you reduce the number of testings, the number of interventions, the number of times follow-up needs to be done. Or at the very least, if you can reduce the interval. So if you can say that, okay, because I've got these tools, now instead of coming back in 3 months, you can come back in 12 months. Even that is pushing the envelope. That is moving the envelope. That's making an impact.
Thanks.
So I think there's a question from Dr. Lenko Parol, I think about various classification techniques and the class imbalance issue. So maybe I'll just talk about this. So I think that's a great point. I think particularly with a lot of the problems that I talked about, you do have a class imbalance problem, quite simply because if you look at the event rate, right? So you talk about an event rate. Now, in this case, you're talking about a cancer diagnosis or an outcome. Invariably, in the general population, right? Even though there's a high diagnostic incidence of cancers, in general, the event rate for cancer, for instance, is going to be much lower compared to a control or a normal. So in other words, every one of these problems, you're going to have imbalance. Okay. Now, one of the things that we try to do is to make sure that when you train your classifier, you try to do it in a way where you try to establish some degree of class balance. And of course, there are other ways, with SMORT and adaptive sampling strategies that you can try to help address those issues. But of course, when it comes to doing the testing, when it comes to doing the validation, you've got to make sure that you don't think about those things. Because if you try to balance out your test set or your validation set, and the problem is that you are now contaminating your test set, right? So it's very critical that if you're trying to achieve class balance, to do it on your training set. But when it comes to your test set, your validation set, you've got to make sure those are completely uncorrupted, unbiased, because any interference there will mean that you've now compromised the fidelity of your test set and therefore the validation of your classifier performance.
So there is a question in the Q&A. Maybe I'll read that out for you.
Sure.
So did you find heterogeneity in the image data collected within US used for the predictive algorithms? And if so, will you be able to comment on treating the same? Yeah.
Absolutely. So unfortunately, I didn't have the time to get into talking about some of the details with respect to heterogeneity. I think this is all the more reason. So just to keep with the theme of the conference about explainable AI, my big point, right? If there's no other point that I made today, the big point I would want to convey is that there's always heterogeneity. And with medical imaging data compared to natural images, there's way more heterogeneity because the scanners that are used to obtain the data are going to inject more heterogeneity into those scans compared to what you might see in other domains. So there's always heterogeneity. And one of the critical things that we have done in our group is to be able to build predictors, build classifiers that are inherently more stable to the heterogeneity, to the variations across different scanners, across different sites. And this is the concern that I have with the more black box, opaque models, with sort of the neural network-based models, because the only way you address the heterogeneity with those models is if you expose all the data from different sites to those models. But that's very difficult to do, right? Because there's only so much heterogeneity or so much data that you could possibly get that you can expose your neural network models to. And so the approach that we take is, okay, we develop these explainable or interpretable imaging biomarkers, but then rigorously test the reproducibility and stability across sites, and then make sure that only the most robust features are the ones that are incorporated into the prediction models. So being able to account for understand the degree of heterogeneity and then understand the features or representations that are most stable to the heterogeneity is an important prerequisite in constructing these predictive models.
Thanks, Professor Anant. Maybe in the interest of time, we'll take one last question and we'll wrap up. So the question is about knowledge transfer. How easy is it to transfer the knowledge for one disease to another, for instance?
Wonderful question. Thank you so much for asking that. I think that's a great question. I think there's a fair amount. One of the things, I'm always baffled by a lot of these studies where one talks about applying a pan-cancer approach, right? So you hear this all the time, a pan-cancer approach, whatever neural network model can predict the cancers across multiple different disease sites. I'm always baffled by this because these cancers, these diseases are so different, right? There's a certain degree of commonality, but there's also a lot of very unique attributes across these different cancers. So, just taking sort of a turnkey approach and saying that, we'll apply this one approach from breast cancer to prostate cancer and other cancers, to me, just doesn't make any sense. Having said that, I think there are a certain set of attributes and certain approaches that are consistent across different cancers. I mean, if you look at, cellular arrangement, nuclear arrangement, there's a certain consistency. You know that cancers in general, there is a breakdown of the arrangement of cells. And so if you look at the cells, I think that is valuable. But there are also nuanced differences. I mean, prostate cancer is something that is very driven by the glands and the arrangement of glands. But that's very different from head and neck cancers, where you tend to look more at the nuclei. So the sort of long and short of it is that there are certain attributes that can be transferred and that you can borrow from one domain to the next. But there's a lot of domain specificity that one has to respect and one should account for in building these models. So, I mean, as I went through the different examples from our group, I think what hopefully got conveyed is the fact that every disease, you have to respect every disease. You have to make the effort to understand your domain and then find what are those attributes of that domain that are particular to that domain that may not be relevant to the other domains. Now, there is some baseline where there is some commonality of approaches that might work across different domains, but there's always going to be unique attributes that you have to learn for a particular domain and make sure to incorporate that into your prediction model.
Thanks, Professor Anant. I think in the interest of time, we'll close the session here. Thanks for the great talk. So there are a few more questions, but if you have some time, maybe you can answer them in the Q&A and the chat box. Thank you very much again for the talk.
Thank you. Thank you for having me. Cheers.